continue our, all right. We'll be continuing our presentations today, and Dr. Yahaya will be doing the first practice question today, question 2A. So, Dr. Yahaya, the floor is yours, please. Go ahead. Thank you.
Okay. Thank you very much, Dr. Enejiro. Good morning, my teachers. Good morning, my colleagues. In the meantime, we are going to discuss question number 2A of just concluded West Africa College of Physicians 2024. The question reads this: a 23-year-old lady. I hope my screen is seen.
Yes, we can see your screen, Dr. Yahaya.
Okay. A 23-year-old lady has episodes of headache, dizziness, and palpitations for 6 months. A CT of her abdomen was done, and the images are presented below. Both axial and coronal views of large cystic mass in the right suprarenal gland, compressing on the medial aspect of the liver. The question that follows are, what is the most likely diagnosis? For some in their centers, I think Ibadan, they were asked, describe what is in the image shown. Then question number 2, is this condition usually benign or malignant? Number 3, will this patient require surgery? Number 4, which precautions or contraindications need to be considered before surgery? Number 5, what will you advise the surgeon to minimize complications during the surgery? Number 6, list drugs that can be used in the treating this condition. So I'll follow the format of quickly answering the questions, then highlighting some key areas, some of the areas that were discussed and some few other ones that have not been discussed with just few slides after. So I'm going to answer the question. The most likely diagnosis is here phaechromocytoma. Reason being that she has headache and she has dizziness and palpitations. And those are some of the cardinal features of phaechromocytoma. However, before the imaging is shown, showing suprarenal mass, a lot of differentials could be considered. One of which is she's a young lady with headache, palpitations, dizziness, and arrhythmia can present like that. So arrhythmia could have been a differential. Then chronic anemia from any other cause can cause with headache, dizziness, and palpitation. Again, some disease like vestibular diseases could present like that. And for a lady of her age, again, one may not rule out hyperthyroidism. However, quickly after the scenario, an image of suprarenal mass is given, that narrows it to phaechromocytoma. Then another question from other center was asked to describe the image shown. Sorry, I should have highlighted the image. I have it in mind, but I've forgotten, okay? But it's there in the question. So to describe the image is a computed tomography scan of the abdomen, showing both axial and coronal views, showing the right large cystic suprarenal mass, approximately measuring 10 by 16 centimeter in size, compressing the medial surface of the liver. So again, it's good to also quickly comment on other structures of the abdomen. Anatomically, they look normal. Again, if there is a contrast, which one of the image is carrying, if there is an enhancement or some changes with the contrast, it's worth mentioning. So this is briefly how to describe.
Dr. Yahaya. Dr. Yahaya, we can't hear you anymore.
Table or room. I don't know where I keep on. No, I can't write today.
All right, I think the service has bumped out Dr. Yahaya. So wait for him to reshare his slides and continue the presentation. Apologies, everyone. Thank you. Recording. Thank you. Please
So
go ahead.
I'll start all over again. So a 68-year-old man with history of cigarette smoking of 40 pack years and recent weight loss of 5 kilograms presented with rashes on the hands as shown in the picture below. He also has difficulty in standing from a sitting position. His serum creatinine kinase was 1,800 units per liter. Question 1, what is the likely diagnosis? 2, what is the cause of the difficulty in standing? 3, what would be the most appropriate next step to make a diagnosis? A, do a CT chest, abdomen and pelvis. B, a nerve conduction study. C, CT of the thymus. D, electromyography. And number 4, what must you do to ensure a good outcome before commencing treatment in these patients? So the first question is, what is the most likely diagnosis? It's paraneoplastic dermatomyositis. Second question is, what is the cause of the difficulty in standing? Is proximal myopathy, which is a feature, a complication of the paraneoplastic dermatomyositis. What investigation should we do? Option A was the correct investigation. We want to do a CT chest, abdomen, and pelvis to look out for a malignancy. And 4, what should be done? The patient should be screened for an age-matched malignancy screening in these patients, as most paraneoplastic dermatomyositis herald a malignancy, sometimes by 2 to 3 years. So you must do a screening and rescreening. And this, and in patients in which you find a cancer, by the time you start treating the malignancy, it helps in resolving the paraneoplastic dermatomyositis. So I have a short note on dermatomyositis and paraneoplastic dermatomyositis. It's an idiopathic inflammatory myopathy with characteristic cutaneous findings that occur in children and adults. It can affect the skin, muscles, and joints. And the overall incidence of the disease is approximately 1 in 100,000, and is 2 to 3 times more common in women. The paraneoplastic subtype, which is seen in up to 30% of adult onset dermatomyositis, DM in this presentation, it stands for dermatomyositis. The most commonly associated malignancies include ovarian, primary breast cancer, colon, lung, prostate, pancreatic, and gastric cancer. The pathophysiology behind the development of dermatomyositis is yet to be fully elucidated. However, it is suspected to result from an underlying alteration in cellular and humoral immunity. It's believed paraneoplastic dermatomyositis is believed to be the result of interaction between several tumor-derived biologic mediators, such as hormones, peptides, antibodies, cytotoxic lymphocytes, and paracrine mediators. The finding of some specific myositis-specific autoantigens, such as histidyl tRNA synthetase, expressed at higher level in myositis muscles, has heightened the possibility of an autoantibody cross-reactivity. And these findings support the possibility that myositis symptoms may result from cross-reactivity between these autoantigens against the cancer cells, as well as those of regenerating cells. So the clinical features, the clinical presentation of dermatomyositis and paraneoplastic dermatomyositis are similar in that a classic photo-distributed pink-violet poikilodermatous eruption develops involving the eyelids, which is called the heliotrope sign, and the V of the chest and upper back, which is called the Scholl sign. In the picture in the question, it showed the man's wrist with some papules on the knuckles with some violaceous pink ulcers, which is the Guthrun's papules, which is a well-marginated violaceous and lichenoid papules that develop over the knuckles, elbow, and ankles. When it's seen over the elbows and ankles, it's called Guthrun's sign. Examination of the hands may show neophotelangiectasias and ragged cuticles, which is called the Samit sign. Associated symptoms may include proximal weakness, muscle pain, and atrophy. So for investigations, you want to do your serum creatinine kinase, which was done in the index patient and was found to be elevated. So these are the muscle enzymes. You want to do your aldolase, your lactate dehydrogenase. There are also some specific immunologic assays that are specific for dermatomyositis, but they are often negative due to low sensitivity, and which is the anti-Me2 and anti-Jo1. You also have the anti-U1 RNP antibodies. The anti-P155 are commonly associated in cases of cancer-associated dermatomyositis, which is most likely the case in these patients who we might be suspecting the primary might be from the lungs because of the history of smoking. You also want to do a muscle biopsy, which is the gold standard for diagnosing dermatomyositis dermatomyositis. And then you also want to do your electromyography and MRI of the affected muscles. So the diagnosis of dermatomyositis is gotten from the Bohan and Peter criteria, which is symmetrical weakness of limb girdle muscles and anterior neck flexors, muscle biopsy evidence with evidence typical of myositis, elevation of the skeletal muscles, particularly the creatinine kinase, typical EMG features of myositis, typical dermatomyositis rash, which includes the heliotrope and the Gottron's papules. For management, adult patients with dermatomyositis should be evaluated for cancer and undergo age and history-appropriate malignancy screening, as up to 30% of all cases of adult dermatomyositis are paraneoplastic, and treatment of the underlying malignancy will usually result in symptom resolution in cases of paraneoplastic dermatomyositis. The approach is usually a multisystemic one with the internal physician, the emergency doctor, in some cases the surgeons, in some of them in who you want to do a surgical approach on some complications, the oncologist, the dermatologist, the neurologist. So therapy can be both general and specific. The general measures include bed rest for those with severe inflammation of the muscles. In patients with muscle weakness, especially kids, a program of physical therapy is used to help prevent contractures that can complicate the disease when they don't move their joints all the time. Also, timing of eating so that they don't aspirate. You want to elevate the head of the bed is also useful so as to prevent secondary bacterial aspiration pneumonitis. So for the muscle disease, you want to give systemic corticosteroids, traditionally prednisone, at a dose of 0.5 to 2 milligram per kg per day, and up to a maximum dose of 60 milligram per day. Other steroid-sparing therapy include methotrexate, mycophenolate mofetil, azathioprine, tacrolimus, and intravenous immunoglobulin has been used for refractory cases. For the skin disease, you want to do sun avoidance, sunscreens and photoprotective clothing like big hats and all of that. You want to use your anti-malarials like hydroxychloroquine and chloroquine. And in those who don't tolerate the anti-malarials, methotrexate is a second option. Thank you very much.
Thank you. Thank you, Dr. Jibola, for that presentation, for that excellent presentation. Now I'll be taking questions and contributions. Dr. Yahaya is back. Questions, contributions. Dr. Yahaya.
Yes, Chief.
Right.
I'm sorry, it was my network of that. Thank you.
No problem. So, questions, contributions for Dr. Jibola, please. Questions, contributions, even from our chiefs that wrote the past exam, to help us with this question.
Hello, good morning, everyone.
Good morning.
Good morning, Dr. Jibola. Thank you for your presentation. I just want to find out if the pictorial diagram and the pictogram was not shown to you, can we have differentials for this patient? I feel yes, it's paraneoplastic dermatomyositis. But what if nothing was shown to you? Because I'm sure the picture guided your diagnosis as well as the history. But what if this was just a history and there was no picture shown to you at first? And they say, can we have differentials for this patient? What do you think?
Yeah, so if, in fact, when I first saw the question, even with the picture, it was still a bit, confusing. So, yeah, so differentials for me would have been small cell lung cancer because of the history of smoking, weight loss. I would have thought of a small cell lung cancer. I would have also thought maybe the patient had some paraneoplastic syndrome from the lung cancer causing all of the above atypical symptoms that had to do with the muscle. I would have thought maybe he had some form of metastatic CNS disease from the lung cancer also because of the CNS picture that was painted here. And then, yes, definitely dermatomyositis would have also come up as part of the differential because of the age and because of the history here that looks like as if there's some form of immunosuppression from a malignancy going on.
All right, thank you, Dr. Jibola. There are some questions in the chat box or contributions. Prof, good morning, sir. You made a contribution. I said national would surely ask for differentials, which you have just answered. Then there was another contribution by Dr. Adebayo Adeyemi saying, thank you for your presentation. Could question 4 be talking about what to do before commencing steroids? Thank you once again.
Yeah, so question 4 was a bit confusing for me when they said, what must you ensure to a good outcome before commencing treatment in this patient? And I had to look at the question a number of times before even actually coming up with an answer for that question 4. And what I found common with literature with patients with paraneoplastic dermatomyositis is that you must screen for malignancy in them as part of like the first approach to management. And that will guide your management as there is no real specific tailored treatment for the paraneoplastic dermatomyositis. But once you treat the underlying malignancy, that has the best prognostic outcome in these patients. So that was the reason why I came up with that answer, that you should be screened for malignancy. And for screening for malignancy, for this patient who has a significant smoking history, you want to do your high-resolution CT scan of the chest. You want to check the thorax, the abdomen, and the pelvis. You want to do tumor markers that will fit into this age. So you definitely want to do your PSA, you want to do your prostate screening, you want to do an abdominopelvic scan, you want to do a digital rectal exam, and all of that. And then it's even said in some literature that some of these patients who present with paraneoplastic dermatomyositis, the cancer might not be obvious until about 2 to 3 years down the line. So you might want to screen them 6 months and 1 year after that, and continuous screening. And also you want to take a good history to rule out a family history of malignancy. Thank you.
Thank you. Dr. Orimolade, please kindly go ahead.
Yes, thank you. Thank you so much to the presenter. I quite agree with you. Just a little of my experience at the exam. What's the most likely diagnosis? They just expected us to say it's dermatomyositis. From the picture that was shown, that was what we felt. So that was what they were looking for, not really paraneoplastic, although at the back of our mind, we knew it could be a paraneoplastic. So it was supposed to be dermatomyositis. So that will now bring us to question 4. So what must you do? Vis-a-vis the fact that we have a background history of cigarette smoking, and like you have said, the major malignancies that could present with the paraneoplastic syndrome as dermatomyositis, you get. So what must you do? Since we know, because I was even trying to say, okay, before I start the steroids, I will have to deworm the. It said no. So they had to explain again. So you have to be sure that it is actually a paraneoplastic syndrome or not, by doing everything that you have said. Because if it's a paraneoplastic syndrome, you treat the malignancy, and most times you might not even really need so much steroids to treat the patients. So you must ensure that this is not a paraneoplastic syndrome, or it is a paraneoplastic syndrome before you actually know what how you will treat the patient. Because if it's a paraneoplastic syndrome and you are given steroids, patient might not really improve. You get the point. So that's what they wanted in question 4. Thank you.
Thank you, Dr. Orimolade. Dr. Success, please. Chief Success. All right. Dr. Success. All right. Prof, please. Good morning, sir. Please kindly go ahead, sir.
Thank
Prof.
you
Oladipo.
for that. So I really agree with the 2 presenters that screening for the malignancy is the answer to that question number 4. We have had live cases where we've had patients that presented with paraneoplastic syndrome, and you keep treating that condition, and they just do not improve. They just do not improve. So, for example, we had this patient that had peripheral neuropathy. And we all know the problem with treating peripheral neuropathy. We did the MRI of the spine. They didn't really see any abnormality, but we kept treating the peripheral neuropathy until one day, for about a year, until one day she presented with hematuria. So we're looking at peripheral neuropathy and hematuria. Something is wrong somewhere. So we just sent for abdominal scan, and it was from the abdominal scan they saw a bladder tumor. So when I said, oh, putting two and two together, bladder tumor, peripheral neoplasty, that means peripheral neoplasty was a yes saying for an underlying malignancy. So what we had to do was send to the urologist. They resected the tumor. They started the chemotherapy for the bladder tumor, and all the features of the peripheral neuropathy just disappeared without needing all the lyrica and all that. Just disappeared that way. So that was part of my case report for my national exam in nephrology derived 10 cases. That was part of my case report. So I'm just trying to emphasize what they're actually silly saying here, that no matter what you do to that dermatomyositis, it will not go except you treat the underlying malignancy that is causing it, just as a life experience. Thank you.
Thank you so much, sir, for that contribution. And do we have any more contributions? Thank you, sir. Any more contributions, questions? Thank you, Dr. Jibola. Please, can you kindly unshare so that Dr. Yahaya, are you in here? Are you in this
Thank you
meeting?
very much.
Thank you. Thank you so much for your presentation. Dr. Yahaya, are you in here?
Yes, okay. Yes,
All right.
sorry. I'm back.
You
Can I
share.
share my screen?
Yes, please. You can share.
Okay, thank you. Is my screen seen?
Yes, we can see your screen.
Okay. Should I go back from the beginning?
Yes, you were just 2 minutes in, 2 to 3 minutes in. You were talking about phaechromocytoma and your differential diagnosis.
Should I go back from the beginning or I should just
From the
continue?
beginning. From the beginning, please.
All right.
We're talking about pheo and the differentials when you logged out, when you were logged out.
Good morning, teachers. Once again, good morning, my colleague. I'm sorry for having a problem with my network. I've started discussing question number 2A about a 23-year-old lady that has episodes of headache, dizziness, and palpitations for 6 months, which her CT of her abdomen showed suprarenal cystic mass in the right suprarenal gland, compressing the middle aspect of the liver. The questions were, what is the most likely diagnosis? And some of the senior colleagues from other centers said they were also described to describe the image. Then, is this condition usually benign or malignant? Will this patient require surgery? Which precautions, contraindication need to be considered before surgery? What will you advise the surgeon to minimize complications during surgery? List drugs that can be used in treating this condition. As I said, I'm going to have a direct approach, then later some few slides about the disease. So the most likely diagnosis, as we said, phaechromocytoma. She's a young lady that had history of palpitation, headache, and also she had for 6 months. She had dizziness, palpitation, and headache. So other differential we said could be chronic anemia, vestibular diseases, hyperthyroidism, and so on. So, but with the image showing a large cystic suprarenal mass, that makes it to look more of phaechromocytoma. So for the other question that said describe the image scene, is a computer tomography scan of the abdomen with both axial and coronal views, showing right large cystic suprarenal mass, approximately measuring 10 by 16 centimeter in size, compressing the middle surface of the liver, and other abdominal structures were apparently normal, and the mass enhanced with contrast. So the question number 2 said, is it a benign or malignant? So it's usually benign, as we can see 90% of the tumor is benign, while 10% is malignant. Then the next question asks about whether she requires surgery. Yes, she requires surgery because she has symptomatic disease and the tumor size is large. And more so, the definitive treatment is surgery. Then precautions and contraindications before surgery. Starting with the precautions, one of the most important things is to maintain the blood pressure below 160/90. In some guidelines, it's as low as 130/90 millimeter of mercury. This is very important. This can be achieved by use of alpha blockade, then followed by beta blockers. Alpha blockers should be given at least for 48 hours before the beta blocker. Reason being that if patient is not properly alpha blockade and beta blocker starts, is known to have a surge in blood pressure, precipitating a form of phaechromocytoma crisis. So alpha blocker drug of choice is phenoxybenzamine given as 0.5 to 4 milligram per kg body weight in 2 or 3 divided doses. Then beta blockers of choice is propranolol, 120 to 40 milligram in 3 to 4 times per day. For some reason, if the patient has contraindication or may not tolerate the above drug, some authorities go ahead to use calcium channel blockers, AC, ARBs, can be used, but they are second line actually. They should not start as a first line. Again, because sometimes during the commencement of the alpha blockade, if beta blockade is rapidly introduced, they tend to have worsening of their blood pressure. So a more rapidly acting alpha blockade is advocated. In this case, IV pentolamine can be used to manage paroxysms, while adequate alpha blockade is awaited. Then other precautions that need to be taken is a disease associated with contracting of the plasma volume is contracted. So you need to do something to expand the plasma, the plasma. So this is achieved by transfusion of whole blood in some recommendation to expand the contracted plasma. And some recommendation choose even fluids, isotonic fluid can be used, and patients should not be deprived of salt intake despite the high blood pressure they come in. And one of the most important is expert anesthetics and experienced surgeon is vital, because if this is done and with use of laparoscopic surgery, mortality is very, very low as less than 2%. So what are the contraindications? Some recommendations did not allow use of labetalol as a first line. However, if there are crises during the treatment, we can use labetalol. Some people may think labetalol has both alpha and beta blockade. Why can't we use that? As I said, we need to initially block beta blockade before, alpha blockade before the use of beta blockers. And again, we have to avoid anything that will further contract the plasma, which in this case, diuretics can do that. So we have to avoid that. There are some other things later in my slide that may be helpful. So what will you advise the surgeon to minimize complications during surgery? One, adequate preoperative preparations is very vital to this patient, in that the blood pressure should maintain as either less than 160/90 or less than 130/90 as some guidelines. Then the heart rate should be normal. And again, patient should be well hydrated. It's very, very important in achieving success in any surgery. Then laparoscopic approach. If possible, it's better to go for laparoscopic approach because it's a highly vascularized tumor. And again, it's a very complicated surgery. So laparoscopic approach, especially for the smaller lesion of less than 8 centimeter in an accessible site, and especially for phaechromocytoma. If they are for paragangliomas, which they usually occur outside the adrenal gland, other surgical modalities like direct resection could be used. However, even at that, laparoscopic approach should be tried, especially for the smaller tumors. During the surgery, use of arterial line, cardiac monitors, and Swan-Ganz catheters should be used because they can have terrible arrhythmias, surge in blood pressure, and problem with the pressures across the heart. So that could be used. Then, if the tumor are bilateral, use of steroids are advocated. Again, for tumor that is intra-adrenal, that is not within the periphery, it's better to remove the entire gland. So then doing vigorous fluid, So to do vigorous fluid replacement on ligation of the adrenal vein, at the point of ligation of the adrenal gland, it's expected that patient will have intense hypotension, very profound. So it's advocated to do vigorous fluid replacement. This is in conjunction with well-experienced surgeons and anesthetics. So what are the drugs that can be used? The drug that can be used, they were drugs that I mentioned above, alpha blockade, preferably phenoxybenzamine. However, prazosin, phentolamine can be used if there are crises. Beta blockade of choice is propranolol. Calcium channel blockers, ACRBs are the second line if the patient cannot tolerate them. Then nitroprusside and labetalol, again, during the surgery, patient may have, because stress or surgical or any medical intervention may lead to the crisis. The blood pressure will go high. So IV nitroprusside and labetalol in that case could be used. And some recommend use of tyrosine as the treatment or during the preoperative period together with alpha and beta blockade. Then glucose should always be there because one of the commonest complications immediately after surgery is hypoglycemia. So vis-a-vis, we can use chemotherapeutic agent. As we can see, 10% of the tumor are malignant, so we may need to use some chemotherapeutic agent. So those are the drugs that can be used. Briefly going to the discussion, we can see phaechromocytoma is a tumor of adrenal gland. We can see the two pairs of adrenal gland looking rectangular. They are usually 4 to 6 grams averagely, and 3 to 5 centimeter in size. We can see the section of the adrenal gland having the outer cortex and the inner medulla. We can see the outer cortex are divided. The cortex are divided into 3 different segments. The outermost layer is zona glomerulosa, which secretes aldosterone. Then the second layer is zona fasciculata, which secretes cortisol, and the innermost layer is zona reticularis, which secretes aldosterone. Sorry. So the inner core is actually, that's where the medulla is, and it secretes catecholamine. So usually tumor occur in the inner core in this case. So this is another diagram showing the various distribution of the wounds in various regions of. So phaechromocytoma and paragangliomas, they are rare catecholamine producing tumors from chromaffin cells derived from the sympathetic and parasympathetic nervous system. 90% occur in the adrenal medulla and they are called phaechromocytomas, while 10% occur elsewhere in the sympathetic chain. In this case, they are called paraganglioma. And some of the sites they occur are head and neck, thorax, para-aortic, urinary bladder, and at the organ of Zuccarandel, which is at the origin of inferior mesenteric arteries. So some of them may be associated with von Hippel-Lindau or MEN2 commonly, and rarely neurofibromatosis type 1, and they're associated with succinate dehydrogenase in rare cases. So the epidemiology, the usual age of onset of this disease is usually around 40 to 60. This is general incidence. However, so many studies have not shown any predilection to whether it affects male or females. And it's seen in 2.8 out of 1 million persons per year, and 0.1% of hypertensive patients harbor a phaechromocytoma. This is a tumor that is also called 10% tumor, in that 10% are bilateral. And if they are bilateral, one needs to look out for other things like maybe it's associated with MEN2A. So 10% are extra-adrenal. We said paragangliomas, they occur extra-adrenal. 10% are malignant, 10% are familial, and 10% occur in multiple. Again, if they are multiple, we should look for von Hippel-Lindau or neurofibromatosis type 1 or MEN2A. Again, 10% occur in children. Some even said 10% are not associated with hypertension, meaning 90% present with hypertension. So this is a brief, because we don't have much time, diagram showing the synthesis of catecholamines from phenylalanine, tyrosine, dihydroxyphenylamine, dopamine, norepinephrine, and epinephrine. So the clinical features, most of the clinical features are due to excess catecholamines. You can see the headache, profuse sweating, palpitation, hypertension, anxiety, weight loss, and paradoxical response to antihypertensives. These are some of the also clinical features. They could present with Takotsubo cardiomyopathy because of their excess catecholamines. The investigation, please pardon me for this. The investigation are divided into urinary, plasma, and imaging. For the urinary, usually we look for metanephrines more than the vinyl mandelic acid, because metanephrines are associated with high sensitivity than vinyl mandelic acid. So fractionated metanephrines, they are very sensitive. You can see they have pulp losses, but they are less specific. However, plasma free metanephrines, they're also more sensitive, and to some extent they are specific. So the recommendation is to have both plasma and urine metanephrines. Again, having done that, we need to image to find where the gland is. If it's we do abdominal CT, which is one of the image prepared, or MRI, we could detect the tumor in the suprarenal gland, just like the index patient. Or we should look at it, we should look for the tumor elsewhere. It could be paraganglioma, so we look along those lines, those sympathetic chain that we mentioned. Then there are other imaging modalities that could be used for, like scintigraphy, MIBG, and some other forms of, so clonidine suppression test, chromogram E, in addition to the normal baseline that will help in evaluating the patient. So I have a diagnostic guideline for the diagnosis of phaechromocytoma. So for diagnosis of phaechromocytoma and paragangliomas, for patients that have the symptoms of the disease, you need to go biochemical testing to properly diagnose. So patient with symptoms mentioned above, we need to check for both plasma-free metanephrines and 24-hour urinary fractionated metanephrines. The normal level of plasma metanephrines is less than 0.5 nanomole per liter, and the normal level of urinary metanephrine is less than 1,200 microgram per 24 hours. So for a patient with symptoms, if you assay that, if they are high as less than, okay, if they are normal, then it's less likely to be that. However, you have to rule out if they are elevated but less than 3 to 4 times above normal level. You also have to rule out other drugs that we see later that may interfere with the excretion of this metabolite of catecholamines. So if they're less than 3 to 4 times normal, you may need to repeat plasma-free metanephrines to confirm reference values and also to rule out other things that associate with rise in this. If they are less than 2 times normal, so it's unlikely to be phaechromocytoma paragangliomas. In that case, you follow up the patient and repeat subsequently. However, if they are more than 2 times normal, this adds more suspicion of the disease, and one should go ahead with the imaging to look for the presence of adrenal tumor. Again, if ab initio is more than 3 to 4 times normal, you don't need to repeat the test. You go for imaging, as we see. You can go for CT or MRI. If you did not detect, you have to do CT or MRI involving all those sites that we mentioned: head and neck, chest, bladder, and other places that we mentioned. Then sometimes you may need to do some functional imaging, which may also help. So the treatment, the definitive treatment is surgery. However, in the absence of surgery, patient can be maintained on medical therapy. And surgical treatment is very important in that it cures most of the patient with hypertension following surgical removal. Their cure of hypertension. So this is just an algorithm about the medical therapy. Initial treatment the goal is to normalize the blood pressure, to prevent minimal organ complication. And in that case, you can in the following order, we use phenoxybenzamine, as I said, beta blocker, metyrosine. Some recommend addition of metyrosine in addition to phenoxybenzamine and beta blockers. Alternative is what we can give, calcium channel blockers, labetalol. Then pre-operative, the target is you want to have a normal blood pressure before the surgery. You also want to have normal volumia. So in that case, you can do adequate fluid resuscitation. You can repeat those drugs given above for initial treatment. Intraoperatively, you have to be very careful of hypercatecholamine, we said, because any stress, any medical evaluation, any surgery may lead to precipitation of the crisis. So catecholamine surge will be high. Then they could have severe hypertension or hypertension, as the case may be. If they have hypertension, sodium nitroprusside, IV beta blockade will be useful. In their absence, we can use labetalol or sodium nitroprusside. Post-operative associated with hypotension and hypoglycemia. These are the predominant complications immediately after surgery, and they need aggressive monitoring. So aggressive fluid intake and glucose replacement should be. So this is for surgical. Complete surgical excision is a definitive treatment for benign and malignant with low morbidity and mortality. As we can say, a laparoscopic approach, adrenalectomy for lesions smaller than SPM is recommended, and if it's done by well-experienced surgeon, anesthetics, and other things, the mortality as low as less than 2%. Then post-surgical is advocated to test for plasma metanephrines 2 weeks post-operatively, And if the results are within the reference range, the section is deemed complete. Again, despite that, we need to obtain plasma methanoreference level yearly for 10 years to ensure that blood pressure is under control. So these are highlights of some of the complications of the disease. You can see hypoglycemia, hypertensive crisis, prolonged hypotension, acute renal failure, arrhythmias, and other. So these are the table showing general precautions about the disease. Some precautions even before taking the sample so that you not get the false positive result. So you have to avoid, there is a recommendation that you use, you tell your patient to avoid these drugs 3 to 5 days before the 24-hour urine collection. Those are the drugs that interfere with the excretion of this methamphetamine, acetaminophen, benzodiazepines, buspirone, caffeine, cocaine, diuretics, dopamine agent, labetalol, levodopa, MAO inhibitors, as we can see. Okay, for preoperative preparation and intraoperative, avoid diuretics as we mentioned above. Don't restrict salt. Avoid beta blockade alone. We said beta blocker in the absence of alpha blockade may need to surge in the blood pressure. So achieve adequate preoperative heart rate and BP control. We said the target is 160, less than 160 over 90, in some cases 130 over 90. To achieve volume, replace state preoperatively with IV fluid. To stop phenoxybenzamine 48 hours before operation. Ideally, if patient is going for surgery, he has to prepare for 2 weeks before the surgery. But some recommend phenoxybenzamine should be stopped on the day of surgery. But again, as we can see from this guideline, it's recommended that 48 hours before the surgery, phenoxybenzamine should be stopped. To keep phentolamine, sodium nitroprusside, because we said there could be surge of catecholamine leading to high blood pressure. To do vigorous fluid displacement on ligation of the adrenal vein, as we mentioned, because at that point, it's noticed that they have profound hypotension because of the excessive bleeding that will occur. Intraadrenal bilateral phaechromocytoma, rule out multiple phaechromocytoma by functional imaging before surgery. So these are my references. Thank you very much for the listening. We entertain some comments, clarifications, and some additions from the exams. Thank you all.
Right. Thank you, Dr. Yaya, for that lucid presentation. Now I'll be taking comments and questions. Are there hands up yet? No. All right, I'm going to start from the chat box. Dr. Olalekon said in the chat, but thank you for your presentation. One of the precautions in the management is for the urologist surgeon to minimize the fumbling. For the management is for the urologist and the surgeon or surgeon to minimize fumbling with their adrenal masses. Thank you mentioned that. Okay, Dr. Tiaminu, please, you have a question or a clarification. Please kindly go ahead, sir. Chief.
Thank you very much for this very good presentation. It's a nice one. And in addition, the crisis can go either way. Can be severe hypotension or severe hypertension. So that is it. So they can go either way. So you have to prepare in surgery or before the surgery, you have to prepare to attend either of the two. So that you have to prepare the emergency requirement to address severe hypotension and the emergency requirements to address severe hypertension should all be available during the surgery. But by and large, it's a very good presentation. Thank you very much.
Thank you, sir. Dr. Remolade, please. Chief.
Yes, thank you so much. Thank you, Dr. Yaya, for that detailed presentation. I think Dr. Tanimwat touched on what I wanted to say because my examiners too were in between the two for me when I was answering the question. So there's one criteria, Rosen criteria, involves most of the things you have said really, but there are classic 4 things. Like in-hospital blood pressure should be greater than the 160/90 that you mentioned for 24 hours before the surgery. Then there must be no orthostatic hypotension with the blood pressure. I can't remember the values now. Then also about due to the catecholamine release, there's also there should be no ST or T wave changes in the last 1 week. And then another thing has to do with the arrhythmias, yes. I'm not sure of the amounts now, but there must be not more than a certain amount of premature ventricular contractions per minute for the patient. So it's the Rosen's criteria. Maybe we should just check it up. So those are the 4 things and the precautions pre-operatively for patients with phaechromocytoma. So the arrhythmias, there is certain amounts, then the ST wave and changes, the orthostatic hypotension, then the hypertension that we've mentioned. Thank you.
Thank you, Chief. Noted.
Yeah.
Thank you, Dr. Malade. Dr. Emmanuel. Sir.
Okay. Yes.
Thank you.
Okay. Good morning, everyone. Yeah. So thanks for the opportunity. So, as an endocrinologist, I will just give 1 or 2 maybe like additional points, from what others have said. The first thing there is that concerning the precautions that was stated in the question, precaution/contraindication as it were. So yes, we talked about the main thing there is that you want to achieve hemodynamic stability. I think the examiner who was at that station was really pleased when I mentioned it like that, hemodynamic stability. So that means you want to achieve, there's a certain level of blood pressure, and then there's a certain level of pulse rate, either on standing, sitting, or either on sitting or supine, lying supine, or standing. I will mention those targets there. And then apart from pulse and blood pressure, also the hematocrit too, you need to check it pre-op. That's because later on, there's a reversal of the alpha-mediated vasoconstriction. When you remove the tumor, that may lead to hemodilution. So you need to check the hematocrit pre-operatively. So those 3 things, BP, pulse, and hematocrit. Now for the BP, the hemodynamic goals pre-op, they include on sitting or supine. Either the patient is sitting or supine. You want the blood pressure to be less than 130/80. That's 1. Then the systolic blood pressure on standing, you want it to be between 90 to 110 systolic. So that's in terms of blood pressure. Now for the pulse, on sitting or supine, you want the pulse to be between 60 to 70 beats per minute. And then on standing, you want the pulse to be between 70 to 80 beats per minute. So those are the hemodynamic goals pre-operatively that you want to achieve. And then I also talked about you need to check the hematocrit for the reason that I said there's reversal of alpha-mediated vasoconstriction may lead to hemodilution. So that's for in terms of the precautions. So definitely the contraindication will be if there is hemodynamic instability. So that's a no for surgery. You have to achieve those goals which I mentioned. Then concerning the other medications in the question, yes, we've talked about alpha blockade, beta blockade, calcium channel. Now going to chemotherapy, that comes in metastatic phaechromocytoma. And there's a particular protocol which I want us to know. It's called the AVABOCH protocol. AVABOCH, that's AVER, then BUCH. AVABOCH protocol. It involves just 3 chemotherapeutic agents: cyclophosphamide, vincristine, and dacarbazine. So it's otherwise called CVD. That's the protocol, CVD. C is cyclophosphamide, B is vincristine, and then the D is dacarbazine. So that you could use that to as chemotherapy for metastatic cases. And then, well, yes, then concerning the, in the discussion now, that I was talking about the rules of 10. Yes, you mentioned, I think like 6. I just want to add more. I think they're up to 10. The classic rules of 10 in phaechromocytoma. They say 10% occur in children. I think you mentioned that. 10 are familial or hereditary. Third, 10% not hypertensive. Fourth, 10% are incidental. 5, 10% are either bilateral / multiple. 6, 10% are extra-adrenal. 7, 10% secrete epinephrine. 8, 10% calcify. 9, 10% are malignant / metastatic. And 10% recur after surgical removal. So that's like 10 points under the classic rule of 10. Then I would like to end by the follow-up after surgery. There are 2 kinds of follow-up. I think the presenter described them. That there's a biochemical follow-up, and then there's a biochemical surveillance. That's the way we call it. Biochemical surveillance, and then the scan surveillance. So for the biochemical surveillance, they said that the catecholamine, you need to assess it between 2 to 6 weeks post-operatively. And then thereafter, in the absence of symptoms, they should be measured annually, but as a matter of urgency with new clinical signs or symptoms. And then you may also want to check chromogranin A. It's also a useful marker. So that's as part of the biochemical surveillance. Now, for the scan surveillance, they said you do you do the scan again, either CT of the adrenal or MRI, depending on which one you have. 3 months post-operatively, 3 months, that should be performed. And then a lifelong follow-up is essential to detect recurrence of benign tumor or metastasis from a malignant tumor, as it is impossible to exclude malignancy on a histologic specimen. So by and large, those were just the points I wanted to add. Thank you very much.
Thank you, sir,
so
for this addition. Thank you.
Thank you so much, sir, Dr. Eguzozie Emmanuel, for that excellent contribution. So I'll be going to the chat box now for some contributions. Dr. Jafar made a contribution in the chat box. She said previously physicians referred to phaechromocytoma as the 10% tumor, meaning the 10% of cases were familial, that's inherited, 10% bilateral, almost the same thing that Dr. Eguzozie said. But recent advances in genetics and phaechromocytoma have compelled physicians to abandon the 10% rule because it is an oversimplification. He also added that the gold standard investigation for definitive staging of phaechromocytoma is FDG PET or PET scan. And FNEC is contraindicated for phaechromocytoma as it can lead to hypertensive crisis. And Dr. Obasi was thanking the presenters for their excellent presentation today. So do we still have any more contributions, questions, clarifications before I hand over the class? Dr. Yahaya, I think you can take over from here. Thank you.
Continue, Chief, sorry. Continue. Maybe Dr. Christabel has 1 or 2 things.
Yes, so hand over to our teachers, Dr. Christabel.
Thank you. Thank you, Dr. Precious. You have this very calm, nice voice. I like it. Keep it up.